All right, so today's talk is going to be about probiotics. We'll touch very briefly on the definition of prebiotics, symbiotics, and postbiotics, which were a new discovery to me. I didn't even realize postbiotics were a thing, but we'll touch briefly on those. But really, it's primarily probiotics that we're going to be touching on. The objectives for the talk are to briefly review the mechanism of action, assess the evidence available for indications of use. While we're assessing the evidence available for indications of use, I want you to think about, your personal practice and formulate a little bit of a plan to implement probiotics into your routine practice. Because I think for most of us, whether you're a primary care provider, whether you're a hospitalist or a subspecialist, there is an area of investigation for your specialty or subspecialty regarding probiotics right now. It's kind of becoming universal that there's something within your area of expertise or application that probiotics are being studied for, and we'll touch a little bit on that as well. We're also going to talk a little bit about the adverse effects and contraindications to probiotics. And then very briefly, we'll review available probiotic formulations. The only reason for that is really for a couple of reasons. Number one, to kind of let you know what's available. I think the more that you know about what is available and what strains are indicated for certain conditions and what strains are available within certain products, how much those products cost, the better equipped you are to implement that into your routine practice. But also just to kind of bring light to the fact that this is an ever expanding industry, and it seems like every day there's something new. And so by no means will that list of formulations be exhaustive, but it is something I think that helps us better understand how to implement that. And so we'll review that very briefly. As far as the disclaimer, I don't have any financial disclosures. I'm not involved in any bench or clinical research for probiotics or prebiotics or symbiotics or postbiotics right now. But I do have the disclaimer that commercial products, as I just mentioned, are listed here. And that's not to tout one product above another. That's really to just provide you with additional information that may be beneficial in how you implement that for your patients. As far as the definition, probiotics are defined as live microorganisms that confer a health benefit when administered in adequate amounts. That was an initial definition that was put out by a joint task force with the Food Agricultural Organization and WHO. There's been a couple attempts in the literature to kind of addend that definition and to exclude certain things like food products that contain large amounts of probiotics within them. But so far, that's really the best definition that we have. As far as prebiotics, those are dietary substances that nurture specific changes in the composition or the activity of gastrointestinal microbiota, favoring a beneficial bacteria and thus conferring a health benefit upon the host. For symbiotics, those are combination products that contain probiotics and prebiotics. And then postbiotics, like I said, kind of a new discovery for me while doing this presentation. These are substances that are produced through the metabolic activity of microorganisms, and they exert a beneficial effect on the host health. And those are things like exopolysaccharides, cell wall fragments, bacterial lysates, short-chain fatty acids, vitamins, and phenols. As far as the mechanism of action, at least what we understand so far, there's multiple ways in which probiotics are beneficial. And so we think that, starting within the lumen, we think that there may be some nutritional benefits. They may help us to break down certain types of food or food products that really don't break down well because of the cell function of our enterocytes. And so that's one way that they may benefit us, is breaking down certain types of undigestible carbohydrate. Whenever we get down to another luminal function, we also think that they block the effects of a lot of pathogenic bacteria. And there's multiple ways in which they're doing this. They're reducing the pH of our intestinal lumen. They're reducing pathogen binding by competing for binding sites. We also think that they may play some role in producing antibacterial bacteriocins in order to decrease that as well. When we get a little bit lower, when we actually get to the cellular function of enterocytes, we think that they promote epithelial cell function. And they do that in multiple different ways. They increase production of mucin, we think, in order to enhance the barrier function and prevent pathogenic bacteria from binding to enterocytes or from getting in between enterocytes. And we also think that they enhance the tight binding junctions that exist in between enterocytes. So there's multiple factors there, from the lumen all the way down to the cellular level. Below the cellular level, when it comes to signaling, we think that they may have neuromodulatory effects, that they induce mu-opioid and cannabinoid receptors on the epithelial cells in order to lower, to lower the sensitivity of this nerve signaling and to increase the threshold at which we have signaling for things like pain and distension. And lastly, we think that they may modulate intestinal immune function, so that we may actually reduce pro-inflammatory cytokines signaling that happens at a deeper level for the intestine. And then we think that this is probably due to cell wall components. Whenever we do a lot of these studies looking at how long probiotics stay within the GI tract and how long they're culturable from our stool, we find that these organisms are probably not setting up shop and colonizing and producing it in large numbers, in detectable numbers. So really, the benefit that we get from probiotics is likely due to the cell wall components and something that we're ingesting. And so that benefit that we get is time bound. We think that as far as colonizing these organisms from the stool, it's usually only 7 to 21 days after our patients stop taking the probiotic. But then lastly, in addition to the effects that we've talked about here, there is some theory that there may be even alteration of gene expression patterns. And that alteration of gene expression patterns leads to improved gut function. And that's a term that's kind of been coined, the metatranscriptome. And so we think that things are happening at a luminal level. We think that things are happening at a cell surface level, but even at a deeper signaling level. And then even beyond that, beyond cell signaling and inflammatory cytokines, that gene expression may be altered by probiotics. So we can see that this is a pretty complex system that we're dealing with. And that gets us into some of these dilemmas with probiotics. I think one of the biggest things that makes this subject really, really interesting, but also a little bit confusing, is the complexity that we're dealing with. So we're introducing live organisms into a patient, which is a living organism, that it contains a huge amount of bacteria that are also living organisms. And so I think a lot of us have kind of heard the study that was published a while ago that kind of put out these kind of numbers comparing the number of cells that we have within our intestinal tract compared to our own human cells, and saying that the number of cells, the bacterial cells within our gut, outnumber our human cells 10 to 1. There's been a couple of other studies and publications that have tried to addend that number and think that it might be a little bit closer to 1.3 to 1, but it's still really interesting to think that the cellular material within our microbiota, within our microbiome, significantly outnumber the cells that we have within our own human body. And whenever we think about the different types of species that are there, that's a little bit mind-numbing as well. There's been greater than 400 different bacterial species that have been cultured, but it's estimated that may only be 20% of the bacterial organisms that exist within our gut. Maybe more than 1,000 that we haven't cultured yet. Plus, our intestinal lumen can contain viruses and fungi. And then there's also ingested and secreted material that are produced by our GI tract. And so this is a really complex system. And whenever we're looking at studies, bear in mind, most of the studies that we're looking at in today's presentation are things like Cochrane reviews and meta-analyses. And I have a couple of randomized control trials in there, but these are really a significant amount of studies with a significant amount of patients, but we are attempting to confer treatment efficacy, a yes or a no, to a system that really has infinite variables. And so it becomes pretty complex quickly. And we just have to bear that in mind, I think, when we're implementing these into our treatment regimens. Also bear in mind that probiotics are deemed a dietary supplement, and as such, they're not FDA regulated, and as such, they do not fall under insurance coverage. And so we have to remember that for our patients as well, especially when it comes to costs, and especially when it comes to different brands that we're using or different types that we're using. And then lastly, what I would say is that, something that's almost universally put out there in these meta-analyses or these Cochrane reviews is that there's a huge amount of heterogeneity when it comes to these studies. Now, bear in mind, a lot of these studies are using a different strain of bacteria or different combinations of different strains. They may be using the same bacteria, but from a different brand. They may be using a different dose as far as how many colony forming units they're putting into a patient. And then there's a huge amount of variability in the duration that they're using this for. And so that's also really difficult to confer a yes or no answer to treatment efficacy when we're considering the heterogeneity of the studies involved. Moving on from there, considering all those factors, we can get into some of the indications for use. So really level A is going to be that there are multiple Cochrane reviews or multiple meta-analyses that kind of go along the same line in order to support treatment, that there's really a moderate to high level of evidence that are generally in agreement. Level B is going to be that there may be some differences in the findings as far as Cochrane reviews or meta-analyses. Or that there's a Cochrane review that supports it and randomized control trials that do not support it. And then level C is going to be that there's a significant amount of conflict between studies and there's not really a consensus, or that there's just randomized control trials out there that support use, but not yet a meta-analysis or a Cochrane review. So we can get into some of that, and I'll kind of list out what I think is some of the best evidence either supporting it or not supporting it. As far as our first indication, antibiotic-associated diarrhea, most of the studies are going to demonstrate a decreased incidence of antibiotic-associated diarrhea whenever we're starting a probiotic at the same time that we're starting an antibiotic. There were a large amount of strains. There was a lot of heterogeneity in the strains that were utilized for these studies, and you see them all listed there. But it did seem like there was a conference of treatment benefit whenever we used larger doses. So 5 times 10 to the 9th greater than or equal to 5 times 10 to the 9th of colony forming units for whatever organism that you're using. And the Cochrane reviews that really support this are Guo et al. And Goldenberg et al. Guo et al. Was actually an update of what Goldenberg had done. And so you see there, they did 33 studies. They had 6,352 patients. And they're showing an antibiotic-associated diarrhea incidence of 8 versus 19% in the probiotic versus control groups. And they felt like there was moderate level evidence in order to support this. And they also demonstrated a risk ratio of 0.45. Now, there's going to be a lot of risk ratios and odds ratios in here. For risk ratio, we're looking at a number of 1.0 being no difference at all. So for this, a 0.45 means that there is a lower incidence of antibiotic-associated diarrhea in the probiotic group. And then we also just have to bear in mind, whenever we're assessing the level of evidence, we have to look at the confidence interval. The null value for risk ratio is going to be 1. And so we don't want our confidence interval to cross 1. And then we'll also look at a lot of number needed to treat for benefit for these studies. And so they had a pretty good risk ratio for this study, but the number needed to treat was a little bit surprising for me, which was 9. 9 patients that needed to be treated for benefit. Goldenberg had very, very similar numbers, but this was just Guo et al. Just updated this and included an additional 10 studies and found a lot more patients within those studies. Move on to irritable bowel syndrome when we're talking about IBS. A lot of these studies are showing decreased pain frequency, severity, and bloating. Those are the primary symptoms for our IBS patients that were affected. And most of the studies were either looking at Bifidobacterium infantis or Lactobacillus rhamnosus GG. And it seems like most of the studies that had Bifidobacterium had a little bit better results than the Lactobacillus GG studies. But bear in mind that none of these studies, regardless of what organism they use, none of these studies showed a significant benefit for stool frequency and consistency. It was primarily pain symptoms and bloating symptoms. So the level of evidence for this comes from a Cochrane review and a meta-analysis as well. Newlove Delgado had 19 randomized controlled trials, 1,453 patients, and their improvement was in their pain scores at 0 to 3 months, and it had an odds ratio of 3.01. So that's really a significant improvement, and they felt like they had moderate level evidence to support that. I think that's good level evidence in order to implement that in our practice. There was another meta-analysis by Horvath et al. That only had 167 patients, and they had a lower risk ratio than the Cochrane review. That was about a 1.70, so an increased chance of decreasing or having an absence of pain, but lower, less significant number there than the Cochrane review. And they had a number needed to treat for benefit of 4, which is that's the primary reason that this meta-analysis is included, is because that's a reasonable number to me. I feel like we see a lot of functional abdominal patients, a lot of IBS patients in GI clinic. And if I feel like I can treat 4 patients and then get a benefit on the next patient that I'm treating, that's a pretty good number to me. Lastly, I included this randomized control trial by Guadagnini et al. Primarily for the last metric there. One of the reasons I included it was because they were using a different brand. They were using VSL number 3, where the others were looking primarily at isolated lactobacillus or isolated bifidobacterium. But they showed some good relief of abdominal pain and bloating. But the last metric, this family assessment of life disruption, I thought was a really important metric that they included, and they showed statistically significant improvement in the family assessment of life disruption after implementing a probiotic regimen compared to placebo. Whenever we're talking about colic, most of the studies that we have show a reduced total daily crying time with greater effects in breastfed infants. In fact, most of these studies didn't really find a statistically significant effect in formula-fed babies, and almost universally, Lactobacillus reuteri was the studied organism. Ong et al. Did a Cochrane review that had 6 studies, 1,886 patients. They didn't show any difference in the incidence of new colic in the development of colic. And in this Cochrane review, they were actually including mothers who started probiotic supplements prior to delivery, and then babies who continued probiotic supplement once they were delivered. And so they didn't show a significant difference in the new incidence of colic, but they did show a mean difference in the daily crying time. And that was a difference of 32.57 minutes per day with a probiotic compared to placebo. They did feel like overall, they felt like they had a low level of evidence. And I think that kind of makes sense when we look at some of our other Cochrane reviews that are including a lot more studies. There was a meta-analysis done by Sung et al. That had 345 patients over 4 randomized controlled trials. The probiotic group averaged less crying time at all points. And then when we get out to their final point, which was day 21, the adjusted change from the patient's baseline was negative 25.4 minutes. And I think whenever we're reviewing these numbers, it's important obviously to have the statistical significance that it bears. We need those values, but also it's important to kind of think of it from the perspective of the patient and the parents. And is 32 minutes less or 25 minutes less in a day going to make a significant amount of difference to our patients? I think most of the families that I'm seeing in clinic with colic and with crying, that's going to be a big difference to them. That's going to be significant. They also demonstrated that the probiotic group was nearly 2 times had 2 times greater likelihood of treatment success at all time points. And their time points were day 7, day 14, and day 21. So at their final time point, day 21, the risk ratio was 1.7. And it was statistically significant. For breastfed infants, the number needed to treat for benefit at 21 days, having success at 21 days was 2.6. And that's, again, a pretty good number for number needed to treat. The effects, as we said earlier, were less significant for formula-fed infants. For the sake of time, we'll skip over those last ones. We've kind of gone in the order of better evidence to lower evidence, except to mention that Harb et al. Did show probably the most significant time difference of negative 55.8 minutes for probiotic babies at day 21. When it comes to regurgitation, I think this was one of our level C evidence. The evidence is not as good, but I included it in there because I was trying to cover a lot of GI primary care overlay. And they did demonstrate, they had some randomized control trials that demonstrated reduced daily regurgitation. This crying in there, crying time is a typo, but it was also showing greater effects in breastfed infants. So for our Garofoli et al., this randomized control trial, they demonstrated reduction in daily regurgitation at week 4, 9 versus 19 mean episodes of reflux, which was statistically significant. And then for Indrio et al., they demonstrated a lower mean regurgitation value, 2.9 versus 4.6, which was also statistically significant for their 589 patients that they had. For acute infectious diarrhea, I was kind of surprised to find that some of the data was a little bit conflicting for this. The initial Cochrane review that came out was by Collison et al., and Allen et al., and they had showed some pretty significant decrease in the duration of diarrhea. Maybe that it decreases your duration by more than a day, and that was statistically significant. Some of the other studies that have come out later, like Collison et al., did an update of this Cochrane review, and they felt like the mean duration that probiotics decreased your diarrheal illness for acute infectious diarrhea was insignificant. They demonstrated that it only decreased your diarrheal duration by 8.64 hours in the probiotic group, and felt like they had low evidence to support its use. And so I feel like acute infectious diarrhea is something that we maybe have a little bit more evidence on now than we did 10 years ago. I think Collison et al. Was in 2020 when they did this Cochrane review. But there may be some evidence to decrease the duration. Moving on to neck, the primary reason I included this was to, if any intensivists were listening, that they have something to pique their interest as well, but also because there was some reasonable level of evidence in order to support it. They showed, most of these Cochrane reviews show a significant reduction in preterm infant severe neck and the associated mortality with neck. Bear in mind that the evidence is largely for babies that are greater than 1,000 grams when they're born. So Sheriff et al. Did 56 trials, over 10,000 patients. Those are the strains. You can see the strains of bacteria there that they're using, and they showed that there was a reduced incidence of neck with a risk ratio of 0.54 and a number needed to treat for benefit of 33. So it seems like the risk ratio is a reasonable number. That looks like a good number as far as the evidence supports, but the number needed to treat seems a little bit large, and they felt like the overall evidence was pretty low quality. They did show a statistically significant reduced mortality rate with a risk ratio of 0.76 and a number needed to treat for benefit of 50. And there was another Cochrane review by Alfela et al., and they also showed reduced severe neck incidence with a pretty similar risk ratio, and then a better reduction in mortality with a risk ratio of 0.65. Some of the other uses, so for people who may not be in primary care or for people who are not managing babies with neck, I've kind of outlined a lot of the other Cochrane reviews here. This is more just a resource since we're kind of running out of time with our talk, but I've given given some thumbs up and thumbs downs for the level of evidence that we have with Cochrane reviews or meta-analyses. These are all indications that have been studied by either Cochrane reviews or meta-analyses, which kind of that blew me away a little bit. I didn't realize there was that degree of evidence in support or against probiotic use in these indications. But it doesn't end there. These are all just subjects. I didn't include all the data in support or against use of probiotics, but just bear in mind that, like I said at the beginning of the talk, whatever your specialty is, whatever your subspecialty is, probiotics are being studied. There is a randomized controlled trial or a meta-analysis or Cochrane review for some sort of application that you have for probiotics, I would almost guarantee. And so this is another just list of things that are being studied right now in randomized controlled trials or meta-analyses. As far as the adverse effects, I think this is one of the reasons that this list of studies that we're doing is so prolific, is because generally these are really well tolerated. We have all these Cochrane reviews and all these meta-analyses, and for most of them at the bottom, when they list out not contraindications, when they list out complications, it's little to none. Some of the things that are listed would be gas or bloating, patients vomiting, having diarrhea, or even an allergic reaction, but that was exceedingly rare. But for the most part, they're exceedingly well tolerated. There are rare case reports of patients having bacteremia from probiotics, culturing out the same strain that they're taking, endocarditis, especially for patients who have a non-native valve. And so that's something we have to be aware of. And then also central line infections for our patients who have long-term central lines. So I wouldn't say that those things, I wouldn't say that if a patient was immunocompromised or had a non-native valve or had a central line, I wouldn't say that those things are absolute contraindications, but I would say that they are something that you need to take serious consideration prior to starting a probiotic for those patients, because their risk is a little bit higher than some of our other patients. Again, these are just formulations. Really, this was published in 2012, and I think it's a really good resource and it's a good starting point. I have it in my mind to update this at some point in time for my own personal use, but I would imagine that the cost for some of these brands might need updating, and then also just the amount of brands that are involved. It seems like every day there's a new probiotic out there, and that's not even crossing into the realm of symbiotics, where there's a probiotic and a prebiotic. That's not crossing into the realm of prebiotics, and then postbiotics now, as well as an ever expanding market. And so I think like everything else that we use, we just have to be aware of what the difference is between bacterial species that may confer a benefit that's supported by evidence, and then some marketing that's put out there that may want us to believe that it's some kind of a new or a different formulation, but really it's marketing that's supporting it. This is that list continued. This is, like I said, more just a resource, so you have it available. If anybody wants this, you can email me and I'll send it out to you, or you can just refer to Kiorba's paper that they did, which was a really good brief review. As far as future directions for probiotics, obviously we want a higher level of evidence to support current indications. We want a higher level of homogeneity with the studies that we're using in order to support probiotics. We also want improved evidence supporting other uses. We listed a lot of Cochrane reviews and meta-analyses for today's presentation, but there's plenty of other uses that we're looking into, and I don't think we need to settle just for a randomized control trial. I think there's more and more meta-analyses being done in order to help us understand what a good level of evidence to support other uses outside of primary care and outside of gastroenterology. Novel strains are something that's on the horizon. Also, isolation of beneficial components of utilized strains. As we talked about at the beginning, it doesn't seem like it's colonization of these organisms that they're setting up shop and proliferating. It seems like it's cell wall components or components that we don't even understand yet. And so if we could isolate those components, and instead of giving a live organism, we can just give that component, we may be able to confer the benefit without any of the risk that we talked about later. And then fecal transplant is obviously an ever-expanding application with similar principles involved, but maybe a lot more complexity involved as well. And so that's just thrown in there for because as gastroenterologists, we like to talk about disgusting things. And then these are my references for the talk. Any questions?
Sir, have you seen any evidence for probiotic use in the treatment of schizophrenia?
I have not. I scoured the Cochrane database in order to try and find every study that I could about probiotics. And I didn't see anything regarding schizophrenia specifically. There's definitely, when it comes to fecal transplant, I know that there's a lot of hot topic research going on about mood disorders and fecal transplant in order to address some of those things. I don't know about schizophrenia specifically, but I know that's starting to be a considered application for depression and anxiety. I don't know the level of evidence supporting that, though, to be honest with you. Check the chat really quickly. All right, I don't see any questions there. I think we'll wrap it up. But if you do have any questions, feel free to send me an email. I appreciate everybody attending and listening.